Module 3, Question 2. So to answer this question, I believe it's first necessary to define and explain a little bit about the autonomic nervous system. So the autonomic nervous system is a component of the peripheral nervous system, and it regulates bodily functions such as heart rate, force of contraction, digestion, respiratory rate, thermoregulation, urination, and things like pupillary response. So it plays a really crucial role in the maintenance of homeostasis. There are two divisions of the autonomic nervous system: the parasympathetic nervous system, which is often referred to as our rest and digest, and the sympathetic nervous system, which is often referred to as our fight or flight. And these systems are dominant under certain conditions within the body. But they both innervate cardiac muscle, smooth muscle, and various endocrine and exocrine glands. There are two neurons within these systems. These are referred to as the preganglionic and postganglionic neurons, and they release the most two common neurotransmitters, which are acetylcholine and noradrenaline. So now I'll talk a little bit about how the cardiovascular system is affected when we age. So overall, there's a decrease in blood vessel elasticity, which increases our systolic pressure and decreases our diastolic pressure. Long-term hypertension can lead to pathological arteriosclerosis, but even in the absence of this, we, in a general sense, have a decrease in arterial wall elastin and an increase in arterial wall collagen. And this results in aortic hardening, overall increasing our afterload. As we age, we also have a stiffer and less compliant heart, and due to Frank Starling's laws, which is related to myocardial stretching, the left ventricle loses its ability to actually contract harder. Left ventricular dysfunction, which can be secondary to MIs or long-term hypertension, results in a passive backflow into the pulmonary vein and into the lungs, and this can result in pulmonary hypertension, which can also lead to right-sided heart failure. As we age, we also have less of an ability for systemic vascular resistance to increase our peripheral blood pressure. And this is due to a decrease in the sensitivity of alpha and beta adrenergic receptors. With age, as well as increasing our incidence of hypertension, we also have an increased incidence of transient hypotension, such as orthostatic or postprandial hypotension. We also have some age-related changes in our respiratory physiology, and as it was documented in our learning material for this week, you have a higher risk of bronchospasm, a decreased ability to clear mucus and secretions, a decreased elastic recoil, increased dead space ventilation, and increased thickness of the alveolar capillary membrane, which reduces gas exchange. So all of these factors will have affected an individual's ability to compensate for something such as a chest infection. As we age, we also have a general decline in our ability to auto-regulate our cerebral blood flow, and this increases the incidence of things like CVA and may contribute to neurodegenerative diseases. It also limits the ability for an elderly individual to compensate for something such as a traumatic brain injury. In a general sense as well, there's also an overall decline in immune function. So the thymus, which is the major organ which is involved in adaptive cell-mediated immunity, atrophies with age. So how would this change our management of a patient pre-hospital? I think first it's really important to be aware and have insight into how this age demographic and their comorbidities firstly increase the susceptibility to contracting an infection, but second to that, recognise that this demographic is more vulnerable to develop sepsis. They are also less likely to be able to compensate for this illness. Sepsis may also be difficult to detect in this population as they may present with atypical symptoms. So early detection of sepsis and prompt transport to hospital for that appropriate broad spectrum antibiotic, ideally within 1 hour, is best practice. Due to decreases in our thermoregulation as well, they may lack the ability to spike a fever or have a temperature, so just be aware of that. You also may want to be conservative with a fluid administration, so immediate approach made the 250 ml aliquots and observing for any negative impact and reassess for signs of fluid overload, such as crackles on auscultation. These patients may have a background of CCF and renal compromise and may be on multiple fluid tablets. The older population also has a higher likelihood of having potentially undiagnosed ischemic heart disease or coronary vascular disease, and giving sympathomimetic drugs such as adrenaline, which we know is relatively non-specific and acts on both alpha-1, beta-1, 2 and 3, may increase the likelihood of these individuals to develop tachyarrhythmias. Noradrenaline is, as we know, mostly acts on alpha receptors, although can act on beta receptors at higher doses, and this is probably more likely to be administered in hospital. So, as I mentioned previously, they're likely to be on a range of medications, and this may actually impact the individual's ability to compensate for an illness, such as ACE inhibitors or beta blockers. So the above factors reduce the ability of an elderly individual to compensate for acute medical episodes, and therefore this may alter our management of these patients. Their past medical history and medications and suspected compensatory abilities should be taken into consideration and guide your treatment. Thank you.